Hello, and you're warmly welcome to this MedAll education program. If it is the first time you're joining a MedAll program, you're especially welcome. MedAll exists to make medical education radically accessible to every colleagues everywhere, always free and always open access. We hope you find today's CME session really useful for your practice. My name is Sankar Navaneethan. I'm a nephrologist and professor of medicine at Baylor College of Medicine. Today, I will be joined on this program by two colleagues, Dr. Robert Busch and Dr. Leigh Perreault. Before we begin, it is important that we share our disclosures with you. The learning objectives for today's session are implement evidence-based CKD screening protocol for patients with type 2 diabetes to ensure early detection and intervention, incorporate GLP-1 RAs into treatment plans for type 2 diabetes and CKD based on current guideline recommendations, apply a deep understanding of the pathophysiological overlap between type 2 diabetes and CKD to implement a multidisciplinary team-based approach that improves patient outcomes. We will have some polls in today's session. You'll be able to answer them using the chat on the right side of the screen or using the chat icon on mobile. If you place the video in full screen, you will need to exit full screen video to answer the polls. We also have some time for question and answers at the end. Please place any questions you have in the chat box. Now let's get started. And now I will hand over to my colleague, Dr. Leigh Perreault. She's a professor of medicine from University of Colorado, who will address the first learning objective.
Hi, everybody. I'm Leigh Perreault. I am an endocrinologist and a professor of medicine at the University of Colorado. Today, we'll be talking about advancing kidney health and diabetes. I just want to first point out that I've moved my practice actually out of our main medical center into a family medicine clinic associated with our university about 20 years ago, where I get to practice side by side with primary care, and I get to see and admire all that they do. So this is really for all of us. And these are the disclosures for myself. So this is our only learning objective, and that is to talk about implementing an evidence-based screening protocol for patients with type 2 diabetes and chronic kidney disease to ensure early detection and intervention. And what we'll do is we'll start out with a case. And I kind of love this case because I feel like all of us have a patient like Sam. So Sam is a 58-year-old gentleman with type 2 diabetes for 13 years. Sometimes he takes his diabetes seriously and sometimes not, right? We've all heard this before. He does not have known complications of his diabetes, but he has not been seen in the past 2 years. His only complaint is pain in his feet. His current medications include metformin, sitagliptin, pioglitazone, hydrochlorothiazide, lisinopril, and simvastatin. His exam is unremarkable except for a BMI of 34, a blood pressure of 145/92, an A1C of 8.5, an LDL of 95, and an eGFR of 55. And I just want everyone to take just a moment to kind of let those numbers and the final two bullet points sort of settle in. So take all that in and think to yourself how you would answer this next question. What would you tackle first? Is BMI, blood pressure, A1C, LDL, or eGFR? All of these things are not terrible, but they're not great. And I think the answer is you could probably tackle just about any of these first. So this next figure comes from a consensus statement that was put forth by the American Diabetes Association in conjunction with the European Association for the Study of Diabetes and published in 2025. And really the answer to the previous question probably centers around really asking Sam what he'd like to tackle first. So where we start is assessing key person characteristics, the individual's priorities. Maybe Sam is really not ready to kind of clean up his diet and become more active, but he is really concerned about his chronic kidney disease because he's had chronic kidney disease in his family and he's seen someone maybe put on dialysis. So he is really motivated by that. Let's think about his clinical characteristics and his motivation, his depression, his ability to do something about his health. So really asking Sam where he wants to start first might be the answer to that question. Then we would consider specific factors that impact choice of treatment. So really talking to Sam about his individualized glycemic and weight goals, and then selecting therapies, either pharmaceutical therapies or otherwise, that would really have a positive impact on his weight, not lead to hypoglycemia, and prevent things like cardiovascular disease and kidney issues. So moving forward, and we would really educate Sam about what we're doing and why we're doing it, and how we're trying to really meet his goals too. And once we come up with a shared decision making and a plan, we would implement that plan, agree on it, implement it, monitor it, and constantly review and agree on the plan, meaning that we really need to constantly reassess how that plan is meeting our goals and Sam's goals. And if we truly were to keep Sam in the center of this decision cycle, being that the goals of care were to prevent complications and optimize quality of life, there's one thing that has not been measured for Sam that is highly relevant to his care, and that is his urinary albumin to creatinine ratio. So how do you integrate UACR testing into routine diabetes care? Do you A, educate your patient about what it means and how you will use it, the result in their care? B, educate yourself about what it means and how you will use the result in patient care. C, educate your staff about what it means and how you will use the result in patient care. D, you could create order sets and customizations in the electronic medical record as a reminder. Or E, all of the above. So think about how you would integrate UACR testing into routine diabetes care. Okay, so what is the UACR and how do we use it? So on this slide, you'll see the so-called heat map. It was developed by an international working group called KDIGO, stands for Kidney Disease Improving Global Outcomes. And you'll see that they show the persistent albuminary categories on the top and the eGFR categories on the left-hand side here. And really, each of these adds specific information that is really multiplicative in terms of the patient's risk. So albuminuria, the way that I describe this to patient is that albuminuria, or the UACR, is really a measure of kidney damage. It is a very sensitive measure of kidney damage, and that usually precedes the decline in kidney function. The eGFR, on the other hand, is a measure of kidney function. So if you think about the kidney as sort of a motor that cleans the blood, a eGFR of 100 can be sort of thought of as like 100% of that motor working. So in our particular patient, we know that his eGFR is 55. So if his UACR is below 30, maybe we'd be concerned about the low eGFR, but we might be reassured by the low UACR. But if the UACR starts to increase and climb and such that it's between 30 and 300, suddenly we're a little bit more concerned. And if it's greater than 300 milligrams per gram, then we're extremely concerned. And extremely concerned for what? So this heat map was developed to really predict the onset of end-stage renal disease. So the prediction of the decline in renal disease. But the truth is that people with kidney disease typically do not die from kidney disease. They actually die from cardiovascular disease. So the heat map has been applied to other conditions. This is a very busy slide, so I'll make it very simple for everybody. There's the age less than 65 shown on the left, age greater than 65 shown on the right. And the point being is that heat map looks really, really similar for the progression of kidney disease as it does for other things, specifically the things that are now included in stars here: all-cause mortality, myocardial infarction, cardiovascular mortality, stroke, heart failure, atrial fibrillation, hospitalization, and peripheral arterial disease. So it's important, as we have that conversation with Sam, to really explain why we're measuring the UACR and how we'll use it in terms of stratifying his risk for not only the progression of kidney disease, but the onset and progression of cardiovascular disease. So how does the risk level determine the frequency of monitoring? So indeed, that progression of the UACR, it not only determines how concerned we are, but how often we actually measure it. So again, here we are with Sam, his eGFR being 55. And so if that UACR comes out to be less than 30, we might check it once a year. So that's the one. If it's between 30 and 300, we would probably check it twice a year. And if it was greater than 300, checking it 3 times per year. So that word treat, what does that mean? It really means that we're treating all of the risk factors that are leading to that increase in UACR and the decline in eGFR, meaning we treat the ABCs of diabetes: A1C, blood pressure, and cholesterol. So how exactly do we treat the ABCs of diabetes? Well, this is a great figure. I really, really love it, showing this sort of pyramid in terms of the progression of care. So what we're showing on the bottom are things of diet, exercise, smoking cessation, and weight. These things are foundational. And it says below these things for diabetes and CKD, but I'd argue for everybody, for anything that's going on with anybody. These are where we start in terms of managing patients with type 2 diabetes and chronic kidney disease. As we move up the pyramid, you're looking at first-line drug therapies. Metformin typically remains first-line drug therapy, but SGLT2 inhibitors have really come into the fold, and I would argue that the use of an SGLT2 inhibitor in a patient with type 2 diabetes and CKD, you should use it independent of the person's A1C. So this means even if the person's A1C is 5.9%, you would still want to use this to prevent the progression of kidney disease. Now, specifically for the treatment of blood pressure, we use RAS blockades, so things like ACE inhibitors or ARBs. And then specifically for the reduction in cholesterol, we use a statin. Recently, GLP-1 receptor agonists have shown benefits for reducing the progression of kidney disease, just like SGLT2 inhibitors. So I would anticipate that the GLP-1 receptor agonist will actually move down to become probably also on the order of first-line drug therapy. And just like the SGLT2 inhibitors, probably should be used in patients with type 2 diabetes and CKD independent of their A1C. Additional drugs with heart and kidney protection include antiplatelet therapies, nonsteroidal mineralocorticoid receptor antagonists. And if we cannot control the ABCs of diabetes with all of these medications that we see here, we'd pretty much use anything under the sun for glycemic control, blood pressure control, and lipid management. There is a meta-analysis looking at the utility of things like empagliflozin, canagliflozin, and dapagliflozin to reduce the progression of composite kidney disease, showing a reduction in the progression of kidney disease by almost 50%. This is so meaningful to patients. And so data from the Credence trial was actually extrapolated to see how much the institution of an SGLT2 inhibitor prolongs the ability for kidneys to continue to work. And so what you're seeing here is the decline in kidney disease for patients in this trial that were randomized to placebo with an eGFR decline of approximately 4.6 milligram per gram per year, or excuse me, mils per minute per year. And really that takes them from a starting eGFR in the middle 50s down to end-stage renal disease as defined as an eGFR of less than 10 in about 10 years. For the patients in this trial that were randomized to active drug, the decline in eGFR is cut more than in half. And so really the time it takes for those folks to go from an eGFR in the middle 50s down to end-stage renal disease is extended by 13 years. So the difference is 10 versus 23 years to reach an eGFR of less than 10. This is really, really meaningful for patients. GLP-1 receptor agonists have also undergone meta-analyses to look at their benefits on progression of chronic kidney disease and type 2 diabetes. Their effect size is maybe not quite as impressive as the SGLT2 inhibitors, but still clinically meaningful. And this has been a kind of a curious finding, and people have wondered how exactly GLP-1 receptor agonists exert their effect. But the truth is their impact may be quite similar to the SGLT2 inhibitors in that they actually work on a little tiny transporter that's in the proximal tubule, the sodium hydrogen cation transporter that lives right next to the SGLT2 transporter. So really, really fascinating how those two drugs may work synergistically to prevent the progression of kidney disease and type 2 diabetes. So if Sam had that UACR in that sort of intermediate range of 150 milligrams per gram, what would it mean for his care? Would he need to know that he was at moderate risk for serious kidney and heart disease? This gets back to educating the patient about why we measure it and what we might do about it. Or B, his EGFR and UACR would need to be checked twice a year. This gets down to us monitoring. How would this number affect what we do? And C, his diabetes medications would need to be adjusted to include an SGLT2 inhibitor and a GLP-1 receptor agonist, if possible. And that gets back to the KDIGO recommendations for first-line treatments, or D, all of the above. Okay, so as we mentioned earlier, Sam had some information at the beginning of his case in terms of what we could use to stratify his risk for the progression of kidney disease, but the UACR was missing. So how can workflows be improved to improve UACR monitoring? Well, first, we need to know who and when to screen. And that for people with type 1 diabetes starts about 5 years after diagnosis. And that's largely on the count that these folks typically are younger and they're usually caught right at the time of the onset of their type 1 diabetes. For people with type 2 diabetes, the recommendation is to start screening the UACR yearly, starting at the time of diagnosis, because these folks typically are older and they frequently go undiagnosed for a fair amount of time. How to screen? We would do a spot UACR and an EGFR. Remember, each of these adds different but complementary information about the risk of progression. What do we do with a positive result? We would repeat it, confirm it, evaluate, and rule out spurious causes. Maybe the person has a UTI or other reasons for kidney problems. We'll consider using cystatin C to improve the precision of the measure of the EGFR, and then only persistent abnormalities define CKD. So defining CKD really requires a persistent elevation of UACR of greater than 30 and or a persistent decline or low EGFR of less than 60 without other evidence of kidney damage. This figure is really, really busy, but it answers a question that I think all of us ask all the time. When should we refer someone to nephrology? And I think if we ask 10 different nephrologists, we might get 10 different answers. So I'm happy that this figure sort of fleshes out exactly what the answer might be. And it's sort of here in the middle. So the answer really is anybody who has a consistent UACR of greater than 700 milligrams per gram. Anybody. Or anybody who has a consistent UACR of greater than 300 with hematuria, or anybody who has an increase in their UACR of greater than or equal to 2 times in people who already have albuminuria that's greater than 30. And I think this is very, very helpful because sometimes this can be a very difficult and unanswered question. Okay, so as we move the needle, good workflows can improve patient care, and they do begin with screening. So which of the following are true? Sam should have been screened for CKD at the time he was diagnosed with his type 2 diabetes and then annually thereafter. B, he should have been screened by EGFR and UACR initially. C, a confirmed and persistent EGFR of less than 60 mils per minute and or a UACR of greater than 30 milligrams per gram indicates CKD. D, a doubling of his UACR would be a reason to refer to nephrology, or E, all of the above. So think about that for just a second. It puts kind of everything together. So thank you for your attention to this program, and I hope that we've met our learning objective.
Good evening, everyone. So this is Sankar Navaneethan, a professor of medicine at Baylor College of Medicine. I will now address the second learning objective of the evening. The focus is going to be how best to incorporate GLP-1 RAs into treatment plans for type 2 diabetes and CKD based on the current guideline recommendations. Here are my disclosures. These were shown earlier. The objectives of this session is that we will review the mechanism of action of GLP-1 RA with particular emphasis on their kidney effects. I will summarize the evidence supporting GLP-1 receptor agonist in those with kidney disease specifically, and how best to incorporate GLP-1 RAs in the therapeutic algorithm while we manage patients with type 2 diabetes and kidney disease. Before we start, we have a polling question for you. In patients with type 2 diabetes and kidney disease, let's say estimated GFR of about 45 and persistent albuminuria, who has already been treated with metformin, an SGLT2 inhibitor, and maximally tolerated RAS blockers, which therapy is the most appropriate next step to improve kidney and cardiovascular outcomes? A, increase the SGLT2 inhibitor to the maximum approved dose. Option B, switch metformin to a sulfonylurea. C, add a DPP-4 inhibitor. D, add a long-acting GLP-1 receptor agonist. E, stop RAS blockade due to albuminuria. I'll give you a few seconds to think over and please complete the poll. All right, thank you everyone for answering. We will move on and hopefully we'll answer this question at the end. Here is a case Vinay, which is similar to the poll that you just completed. A 56-year-old female with type 2 diabetes, hypertension, and hyperlipidemia was seen in your office for management of her chronic medical conditions. The current medications include losartan, metformin, empagliflozin, and atorvastatin. Her exam showed a blood pressure of 132/84 and a BMI of 29. Her relevant laboratory parameters include hemoglobin A1C of 7%, a creatinine of 1.5 that approximates an estimated GFR of 45 ml per minute, with a UACR of 380 milligram per gram. Her previous echo showed left ventricular hypertrophy. What is the next best therapeutic option to optimize her care? The topic today is the GLP-1 receptor agonist. The GLP-1 are secreted by the L cells in the small intestine, which have myriad of effects, as you could see in this slide. The GLP-1 receptors that are present at various tissues throughout the body. The primary action starts with the increase in the insulin secretion, which is glucose dependent. There's also decrease in glucagon secretion, which combined together with the increased insulin secretion leads to the hyperglycemia or the hypoglycemic effects. The notable effects on the gastric emptying, the decrease in the gastric emptying, and the decrease in acid secretion, and the effects on the brain, especially the decreased food intake and the increased satiety that comes with the GLP-1, leads to the weight loss effects. In addition to the hyperglycemia or hypoglycemia and the weight loss effects, there are other effects that are also noted. We have now cardiovascular studies that have demonstrated that the GLP-1 improves cardiovascular outcomes in those with type 2 diabetes. There is data now have evolved for obstructive sleep apnea management and also for MASH. As such, the current role for GLP-1 RA, there is FDA approval for management of obesity, glycemic control, cardiovascular risk reduction, sleep apnea, metabolic dysfunction associated steatohepatitis, and of course for kidney disease. How does GLP-1 agonist provide kidney protection? So there are two, one, direct kidney effects, and there are indirect kidney effects. We'll focus first on the indirect effects. There is obesity, hypertension, dyslipidemia, and diabetes that often accompanies patients with kidney disease. And these four are independent risk factors for kidney disease. And GLP-1 receptor agonist cause weight loss, reduces blood glucose, improves lipids, and reduces blood pressure. So therefore, you would anticipate that all these cumulatively would protect the kidneys. On the other side, you see that there are direct kidney effects. This is the topic of focus these days. We have an ongoing study that is looking at whether the GLP-1 agonist causes direct kidney effects. This is done by conducting MRIs and kidney biopsies in patients with kidney disease to see what are the direct effects of GLP-1 RAs on the kidneys. But in short, what has been reported so far is there is an improvement in glomerular hyperfiltration. There is improvement in the kidney hypoxia. There is reduction in the inflammatory burden within the glomerulus. There is improvement in the lipotoxicity by the reduction in the reduction in the body weight, and also improvement in sodium retention. Cumulatively, these all lead to better kidney protection, as we would see in the outcome trials. We will now review the evidence, the clinical trial evidence that supports the use of GLP-1 receptor agonist in CKD population. It started with the LEADER trial. LEADER trial focused on liraglutide and cardiovascular outcomes in the general population with type 2 diabetes. The primary results showed there was an improvement in cardiovascular outcomes, and a secondary analysis that showed that there was improvement in the composite renal outcomes. In the composite renal outcome, the most important measure was there was an improvement in the new onset persistent macroalbuminuria. However, the renal replacement therapy, i.e. needing dialysis or death due to renal disease, there was no significant benefits. But of course, the study was not powered to detect. But this study put on the limelight that potentially the GLP-1 RA can have significant kidney benefits. This was more so confirmed in a large dedicated kidney disease trial called FLOW-CKD trial. The trial enrolled about 3,500 patients with type 2 diabetes and CKD. Kidney disease was defined by an eGFR of 50 to 75 and a UACR of over 300 and less than 5 gram per gram, or an estimated GFR 25 to 50 and a UACR over 100 milligram per gram to less than 5 gram per gram. The intervention in this case was semaglutide, 1 milligram weekly. The dose was not increased, and it was compared to placebo. But the primary outcome measure was the major kidney disease events. It's a composite of the onset of kidney failure. Either they needed dialysis, transplantation, or if their kidney function hit eGFR less than 15, or if they had a death from kidney disease or cardiovascular disease. The primary results showed there was a 24% reduction in the first major kidney disease event. And if you look at the kidney disease specific component events, there was also about a 21% reduction in several of the kidney disease specific component events. What is more interesting is in this patients with type 2 diabetes and CKD, both the first major cardiovascular events and the death from any cause, not just from cardiovascular disease, but death from any cause, there was almost a 20% reduction in these risks. There were also improvement in metabolic outcomes and adverse events. For instance, the most notable thing was there was about a 4 kilo reduction in the body weight. And again, it's important to note the dose was about only 1 milligram subcutaneous, and the dose was not titrated. So this was not intended for weight reduction. The study was intended to see if these drugs provide kidney benefits. The glycated hemoglobin level dropped by about 0.8%. There was a modest improvement in systolic blood pressure, while there was no improvement in diastolic blood pressure. The notable thing is the serious adverse event rate was actually lower in semaglutide overall, even though there was a higher permanent discontinuation slightly, as you could see, 13% versus almost 12%, which was actually due to the higher GI side effects, which are well known with these class of agents. The FLOW-CKD was the largest study, but prior to this, there were also general population studies that have enrolled patients with kidney disease. This is a meta-analysis in which the investigators pooled data from 12 randomized controlled trials. There were 18,000 patients who had kidney function below 60. When you compare that population GLP-1 to placebo, clearly there was an improvement in composite kidney outcomes. There was about 15% reduction in the kidney adverse events. There was a 14% improvement in the cardiovascular outcome, with a 23% reduction in all-cause mortality, convincingly showing that the GLP-1 receptor agonist improved kidney and cardiovascular outcomes and survival in patients with CKD. Now, the question is, what in patients without pre-existing kidney disease? In people without CKD at baseline, would these agents prevent the onset of albuminuria and slow the rate of eGFR decline? The answer is yes. This is a meta-analysis wherein authors pooled studies conducted in the general population, excluding the patients with pre-existing CKD. And they show here that there was a 24% reduction in incident microalbuminuria with the use of GLP-1 RA, and again showing potentially the kidney benefits even among those without pre-existing CKD. The adverse events with GLP-1 RA, and this is a study that compared tirzepatide, the GLP-1/GIP, to GLP-1 RA alone. And comparing both those agents, you can clearly see the GI side effects that predominantly happens with either one of these agents. You could see nausea happening in about two-thirds of the population, constipation happening in about 25 to 30%, diarrhea happening in an equal proportion with other side effects. And these side effects that have been seen in the general population are fairly comparable to what was actually seen in the FLOW-CKD trial, suggesting that the adverse event profile is comparable, at least in the patients with CKD. What does guideline recommends regarding the use of these agents? Before we review the guidelines, here is another polling question for you. According to KDIGO and ADA recommendations, when should GLP-1 RAs be used in patients with type 2 diabetes and CKD? Option A, as first-line therapy before metformin or SGLT2 inhibitors. B, when glycemic targets are not met despite metformin and SGLT2 inhibitor therapy. C, only when albuminuria is absent and kidney function is normal. D, only when advanced CKD requiring dialysis patients. Option E, in combination with DPP-4 inhibitors to enhance glucose lowering. I'll give you 10 seconds. Excellent. The right answer is, you're going to see that in the next few slides, but certainly the option is B here. This is the KDIGO, which is the kidney-specific guidelines by the KDIGO organizations focusing on how to manage type 2 diabetes and patients with type 2 diabetes and CKD. This was issued in 2022, which is being revised right now. Based on the evidence, at that point, we did not have FLOW-CKD trial. So in the absence of that, it was a 1B recommendation that in patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets despite the use of metformin, SGLT2, GLP-1, long-acting GLP-1 RA are recommended for this population. The most recent ADA standards of care, the 2026, have updated, and of course, they do have access to the most recent FLOW-CKD data. The current recommendation is again creating the pillars of care based on the lifestyle modifications. After that, add RAS inhibitors. Then the options are either depending on what the individual profile, the patient profile looks like. SGLT2 inhibitors is recommended if the eGFR is over 20, and they can be continued until dialysis. But of course, the GLP-1 receptor agonists are options if the patients need additional conditions, situations like weight loss, if they have a better glycemic control is warranted. If they have underlying liver disease, then GLP-1 RA may be preferred. What are some of the recommended dose for various GLP-1 receptor agonist and CKD populations? So this comes from the KDIGO guidelines, which suggest that there are certain GLP-1 RA for which no dosage adjustment is needed, and certain agents such as exenatide may not be used in patients with creatinine clearance under 30. On the other hand, semaglutide, no dosage adjustment is needed, and limited data exists for severe CKD. We don't have dedicated clinical trials in patients with dialysis for these agents. However, a large observational study utilizing the United States renal data system showed that GLP-1 receptor agonists can be used for weight loss in dialysis population. It leads to an average weight loss of about 4 to 5 kilos, which we actually saw in the FLOW-CKD trial also. The GLP-1 RA in diabetes and dialysis was associated with a 23% lower mortality and a 66% higher chance of transplant listing. There was no higher risk of acute pancreatitis, biliary complications, or medullary thyroid cancer. Obviously, this is a large observational study with its own limitations, but at least showing a possibility that these drugs could facilitate kidney transplant listing and maybe better outcomes for dialysis population. There are several ongoing trials at the moment. This is a rapidly evolving field. We have now combining monotherapy such as GLP-1 receptor agonist. You have dual agonist, GLP-1 and GIP-1 receptor agonist. You also now have triple agonists such as GLP-1, GIP, and glucagon agonist. The trials are ongoing. In the next couple of years, we're anticipated to see more data coming out addressing whether one is better than the dual combination versus triple agonists. We'll come back to this case that we talked about earlier. You may recall that this is a patient with type 2 diabetes, hypertension, and hyperlipidemia, optimized medically so far, still with a BMI of 29 and an elevated blood pressure, still have an elevated albuminuria warranting further therapy. The option here obviously is the GLP-1. The patient could benefit from some weight loss, definitely. Independently, it could lead to a reduction in albuminuria and better outcome. Use of GLP-1 would also lower the hemoglobin A1C, offering triple approaches here for the kidney benefits. And the patient is already optimized on other agents, warranting that this is the appropriate next step. So in conclusion, I have shown you data that GLP-1 receptor agonist improves metabolic parameters. It reduces body weight and obviously leads to better cardiovascular and kidney outcomes in those with type 2 diabetes and kidney disease. Use of GLP-1 RA may reduce the incidence of albuminuria among those with diabetes and no pre-existing kidney disease. GLP-1 RA use in dialysis population may facilitate weight loss and listing for kidney transplant. The adverse event rates reported in these trials are fairly comparable to reports from the general population. Thank you so much for listening, and I would appreciate any questions.
Hi, my name is Bob Busch. I'm an endocrinologist in Albany, New York, and director of clinical research. And we did some of the studies that I'll be reviewing with you. And we're going to talk about the overlap between type 2 diabetes and chronic kidney disease to implement a multidisciplinary team approach that improves patient outcomes. It's not just endos or nephrologists or primary care who manages diabetic nephropathy. Well, it's a team approach, including the patient in the center, but pharmacists as well. So many of us are spoiled working with PharmDs who help out identify patients and tweak the medications appropriately. So that's what we'll be covering in the next half hour. The main objective is to get a deeper understanding of the pathophysiology of diabetes, the overlap of diabetes, chronic kidney disease, to have this multidisciplinary team approach. These are my disclosures. Most of them are doing clinical trials with a variety of pharmaceutical companies, and some of these trials we'll be reviewing later on. So first polling question: which mechanism best explains why type 2 diabetes, cardiovascular disease, and chronic kidney disease overlap with each other? And you have these answers here, and I'll give you some time to answer. So here's the overlap where you have people who have diabetes, heart disease, heart failure, atherosclerotic heart disease, so they all overlap with each other. And, that's why they call it cardiorenal clinic. In fact, some hospitals are setting up cardiac, renal, metabolic, DCRM, diabetes, cardiac, renal, and metabolic as well, because of this tremendous overlap that they were all cross-trained in this. So you can see in the United States, 34 million Americans have diabetes, mainly type 2. Many of these patients have chronic kidney disease, and oftentimes it's not diagnosed until it's stage 4 or stage 5, because no one did a urine microalbumin, or they may have done a GFR, but they didn't do a urine microalbumin. That certainly is important to know if there's kidney damage somewhere. And then heart failure is very common. You've all heard in medical school that the kidneys want to be wet, the heart wants to be dry. So if you have heart failure and less blood volume, you get worsening kidney disease and so on. If you volume deplete the patient, you get worse kidney disease when you're trying to treat the heart failure. And if you have diabetes and heart failure, it has tremendously high mortality. Now, why this link of all these things? Well, we have chronic inflammation at the top, and then you have endothelial dysfunction, where you can get vasoconstriction because of the impaired nitric oxide production. And then you get oxidative stress by reactive oxygen species being made and mitochondrial dysfunction. And then it's a vicious cycle. Once you get more of inflammation and more oxidative stress, you get more inflammation and so on. So the cycle continues. And that's why you want to get this under control as early on as you could identify with a patient to benefit your patient. Now, what are these factors going on? Well, you have hemodynamic factors on the right. So if you have a vasodilatation of the afferent arteriole inappropriately, you flood the glomerulus. And if you inappropriate vasoconstriction of the efferent arteriole, then you get worsening glomerular pressure and leakage of proteins and other factors from the glomerulus. So that comes on by more RAS activation, you can get fluid overload, etc. But then you have the metabolic factors, the hyperglycemia and dyslipidemia that can lead to inflammation and fibrosis. So this combination of things, you end up with cardiorenal syndromes, and the diabetes as a systemic disorder can lead to these multiple problems with heart, with atherosclerosis, and with kidneys with inflammation. Now, how do you reduce diabetes complications? Well, you need improved glycemic control with drugs that are heart smart or renally smart, good blood pressure management, also with drugs that are renally smart, lipid management and aggressive lipid management, particularly if the patient has atherosclerosis. You know, the renal patient is an atherosclerotic equivalent, and you want to get the LDL as low as possible, oftentimes below 70 or below 55, with statins and other therapies as well. And then we want to think of agents that specifically benefit the heart and the kidney. Some of these are diabetes agents, drugs that we treat diabetes with, and others are drugs that are specific for blood pressure that may cause dilatation, for example, of the efferent arteriole. Now, fortunately or unfortunately, in about 2007, 2008, the glitazones were beaten up by the FDA, and they said every new diabetes drug had to have a cardiac outcome study showing safety. And it was because of this decision by the FDA that all of these trials were pursued to see, was the drug, a diabetes drug, safe for the heart. But then the spin-off of this is in some of these diabetes studies for cardiac safety, they found there was renal benefit, and that led to dedicated renal trials. So first the cardiac studies occurred, and then we had dedicated renal studies that showed a diabetes drug would specifically benefit the kidney, aside from the heart safety. Most of the studies were done originally for heart safety until EMPA-REG came out that showed cardiac benefit using empagliflozin and SGLT2. But in the SGLT2 studies, it showed those had renal benefits as well. So then there were dedicated renal studies that I'll be reviewing with you. So how do you protect the kidneys? Besides good diabetes control and not giving nephrotoxic drugs like X-ray dye studies or no X-ray dye, no NSAIDs, no COX-2s, what else can you do to protect the kidneys? Well, it turns out that the SGLT2 studies that showed cardiac benefit, whether it was EMPA-REG showing that empagliflozin lowered MI stroke death and lowered cardiac death by 38%, or the CANVAS program with canagliflozin showing it lowered MI stroke and death, or the DECLARE trial with dapagliflozin that showed that it also lowered heart failure. These were cardiac studies, but in those cardiac studies, if each of them showed renal benefit. And in fact, you could see on the right-hand side how much renal benefit there was to lower end-stage renal disease or lower GFR by 40%. So because these cardiac studies showed this, each of the companies making these drugs decided we'll do a dedicated renal study to look to see renal benefit to get the renal indication. Why did they do this? Because up until these SGLT2s was studied, the only drug that was approved to benefit kidneys in type 2 were the ARBs. So the RENAL trial showed losartan lowered end-stage renal disease by 16%, and the irbesartan diabetes nephropathy trial showed irbesartan with similar blood pressure control to amlodipine lowered renal risk by 20%. So all of a sudden, RASs were in the drinking water to dilate the efferent arteriole, to have hemodynamic benefit, to allow glomerular pressure to lower by dilating the outflow from the kidney or the efferent arteriole. Well, then we had a flurry of all of these SGLT2 studies. We had the CANVAS trial published in New England Journal in type 2 diabetes with patients with type 2 who had proteinuria and a GFR above 30. And they had 4,000 patients in the study giving canagliflozin, and after 2.5 years, looking for a composite of end-stage renal disease, doubling of creatinine, or renal or cardiac death, what was found? 30% lowering of end-stage renal disease. So all of a sudden, canagliflozin got the indication for this. And the thinking was, when you gave an SGLT2 and urinating out sugar, salt, and water, more sodium was going past the macula densa, and therefore there was a compensatory constriction of the afferent arteriole. So constricting the inflow and dilating the outflow led to renal benefit. Similarly, dapagliflozin did the study called DAPA-CKD. Similar study, 4,000 patients looking for end-stage renal disease. Again, after 2.5 years, looking at decline of GFR 50% by 50%, or end-stage renal disease, which is dialysis or transplant, or end-stage renal disease, or they looked at cardiac or renal problems. What they found in the DAPA-CKD, 39% lowering of the primary renal composite. So once again, dapagliflozin, another SGLT2, had benefit. And finally, empagliflozin in the EMPA-Kidney study, similar type study, patients with diabetes or without diabetes. So with or without diabetes, having used an SGLT2 such as empagliflozin, lowered events by 28%, lowered end-stage renal disease, or lowering GFR by 40%, or cardiac or renal death. So all three of these SGLT2s have that indication, and all of a sudden now we have another drug that we could use, an ACE or an ARB to dilate the outflow from the kidney, or an SGLT2 to constrict the inflow to the kidney. Now, in these studies, what was found is it didn't matter whether you had diabetes or not, whether your GFR were very low or not very low, whether you had proteinuria, it worked. So SGLT2s worked to lower end-stage renal disease. Now, early on, when you give an SGLT2, you may notice the creatinine bumps slightly when you volume deplete the person, but then there's a leveling off of the GFR, whereas the GFR constantly falls when you're giving placebo. So the GFR, slope of the GFR is important. And in the future, they may just look at slope of GFR and not do these long-term dedicated renal studies. So these were all, remember, started because of those cardiac studies. That in those cardiac studies, the renal outcomes were markedly improved. So across the board, and actually in this week's Journal of American Medical Association, they talk about the importance of SGLT2s being given to prevent kidney disease and diabetes. And why does it work? Well, here's a normal kidney. So there's the glomerulus. And when you have a lot of reabsorption of glucose at the proximal tubule, you reabsorb sugar, salt, and water. Less salt is passing down here. The macula densa says, uh-oh, less salt. I must be volume depleted. And it dilates the afferent arteriole, the inflow to the proximal, the inflow to the glomerulus. Remember, before we said the ACE or ARB dilates the outflow. Here, now you're dilating the inflow. You don't want to do that or you'll flood the glomerulus. So when you give an SGLT2 and block the absorption of sugar, salt, and water, you're delivering more salt to the macula densa, which has increased sodium delivery there, and you constrict the afferent arteriole. So you constrict the inflow because you think you're losing too much salt. So less in, more out, you benefit the glomerulus, and that's how SGLT2s benefit the kidneys. So far we said RAS blockers will dilate the outflow from the glomerulus, and SGLT2s constrict the inflow. So next polling question. Of the three major drivers of chronic, what are the drivers of which one of the three major drivers can lead to progression of chronic kidney disease? Alterations, and here I'll let you read them. Alterations in renal sodium handling, hemodynamic factors which will result in elevated intraglomerular pressure, reduced renal perfusion, declines in proximal tubular reabsorption over time, or variability. So far we talked about RAS blockers and we talked about SGLT2s. So now we'll talk about other drivers of chronic kidney disease, inflammation and fibrosis. So we talked about the hemodynamic factors, we talked about metabolic factors with sugar being high, but what about inflammation and fibrosis? We talked about that earlier on in the pathophysiology of inflammation and fibrosis. Well, it's known that aldosterone in lab rats causes a lot of inflammation and fibrosis. So giving a specific aldosterone blocker, such as finerenone, which is a non-steroidal mineralocorticoid blocker that blocks aldosterone activity, by giving that, it was felt that might benefit the kidneys since aldosterone can lead to inflammation and fibrosis in rats. So they did some preliminary studies, some phase 2 studies called ARTS-DN, where they gave finerenone and it lowered proteinuria, independent of blood pressure changes. So that led to a specific study with finerenone called Fidelio, where they had 5,600 patients with diabetes who had some proteinuria, and what they looked at, like in the other studies, sustained decrease of GFR by 40%, renal death, and they compared patients on finerenone versus placebo. Some of them were already on, they were all on a RAS, and some were on an SGLT2. And the bottom line of the study was an 18% lowering of end-stage renal disease on top of the RAS blocker. Remember, all those SGLT2 studies were also on top of a RAS blocker. Now, how'd you get into the study? You had to be over 18, you had to have proteinuria, and you had to have a potassium that was reasonable, otherwise you can get hyperkalemic from this, and you had to have some albuminuria. How much albuminuria? You could see your urine micral was 30 to 299 or over 300, but 30 to 299 you got in if you had retinopathy. But if you had a lot of albuminuria, you didn't have to have retinopathy. So that's what got you into the study. And the punchline of that study in the Fidelio trial, you got 10 to 20 milligrams of finerenone versus placebo, and they looked at time to kidney failure, meaning end-stage renal disease, 40% lowering of GFR, or renal death. And the bottom line of that study was an 18% lowering. So 18% lowering of that endpoint. So now we've gone over RAS blockers having benefit in the RENAL trial. Now we have SGLT2s having benefit in the 3 studies I went over before. And now the Fidelio trial shows finerenone does it by a different way, by lowering inflammation and fibrosis. So the knowledge up to this point was RENAL showed residual risk reduction with losartan or irbesartan. The SGLT2 studies we reviewed, each were positive studied with lower renal risk, and now the Fidelio trial. So you have multiple ways of benefiting the kidney. What about using 2 ways together? So then there was a study called Confidence trial, where they used finerenone along with empagliflozin, an SGLT2 and an aldo blocker. The aldo blocker would lower inflammation and fibrosis. The SGLT2 would constrict the afferent arteriole. Remember the RAS blocker, which they were all on a RAS, dilated the efferent arteriole. And these patients were already on a RAS blocker, and a third got finerenone, a third got empagliflozin, and a third got both together. And what did they find? This is urine microalbumin, dramatically dropped with both versus either one. Either one worked, but both dropped it a lot more. So that was what was seen in the study, with some lowering of GFR in the beginning, but then it tends to level off over time. And here we see that the blood pressure dropped with each of them. And interestingly, usually empagliflozin will offset some of the hyperkalemia of finerenone, although in this study it didn't, but many studies it does. So the conclusion of this study is if you have chronic kidney disease and diabetes, you could give both drugs, finerenone and empagliflozin, an aldo blocker and an SGLT2, to have additional renal benefit on top of the RAS inhibitor. Now, despite all these great drugs, dialysis is still very common in end-stage kidney disease. So what about this other big class of drug that we've used for years, the GLP-1s? Well, there was a meta-analysis of all the GLP studies where they had not only cardiac outcomes, but they also looked at what happened to the kidneys in these studies. And this is what was looked at before the FLOW trial, which is a dedicated renal study using semaglutide, which you're going to hear a little bit about in my talk and more about in some of the other talks. So here, this meta-analysis looked at 11 GLP trials with lots of participants in each trial where the renal results were given. And we're not going to go over every trial, but in each of these big studies that were done with GLPs looking for cardiac safety or benefit, overall, there was a 19% lowering of end-stage kidney disease, of composite kidney outcome. Very suggestive. You couldn't get a label approved because of this, of the meta-analysis, but this led to the FLOW trial looking at semaglutide specifically. Now, you all know GLPs not only will lower end-stage renal disease, as you could see here in the meta-analysis, and worsening kidney function, but also they have lowering of cardiac events and strokes and other things like that. So GLP-1s are wonderful drugs for not only for the weight reduction and A1C lowering, but for cardiac benefit and implying renal benefit here. So that's what these studies showed. And it didn't matter if old, young, heavy, not heavy, whether they were given weekly or daily, they all had some renal benefit as well. So this meta-analysis concluded that GLP-1 receptor agonists reduce the risk of kidney disease as well as cardiac disease and overall death. So this led to a dedicated renal study called the FLOW trial. The FLOW trial was a study done with semaglutide, and semaglutide was used in patients with type 2 diabetes who had some proteinuria, and what they looked at was lowering the first kidney event, lowering of GFR or renal or cardiac death or dialysis or transplant, and it lowered it by 24%. The GFR slope also was improved compared to placebo. MI stroke and death went down dramatically by 18%, and in that study, 20% lowering of death in general. So in this dedicated renal study with semaglutide, just like you had a dedicated finerenone study with an aldo blocker and a dedicated SGLT2 studies with the 3 studies I reviewed earlier, GLP-1s also benefited end-stage renal disease and prevented kidney disease. So now we had several different drugs that work to benefit the kidneys. So which combination best reflects how current therapies target key drivers of chronic kidney disease progression and type 2 diabetes? RAS and SGLT2, GLP-1 and SGLT2, finerenone and RAS. So you have different mix and match combinations, or all 3 of them target a different driver of kidney disease that we've discussed previously. So our pillars of therapy are RAS blockade to dilate the efferent arteriole, SGLT2s to constrict the afferent arteriole, finerenone that stops inflammation and fibrosis, and now semaglutide. It's not clear why semaglutide has the benefit. Is it the weight reduction? Is it anti-inflammatory? Does it stop oxidative stress? Is there a receptor in the kidney that has direct benefit? So you have pillars of therapy when you treat a patient. When you find they have kidney disease and their urine microl is elevated and their GFR is going down, Sometimes we throw the book at the patient. If this patient still has a problem on a RAS, add an SGLT2 or add finerenone or add semaglutide, or sometimes all four of them are done as a pillar of therapy that will have renal benefit. Just like you have pillars of therapy for heart failure with beta blockers and SGLT2s and the Entresto type drug or other drugs that benefit the heart. And they have pillars of therapy that you give a patient right when they have heart failure. Many of our colleagues might give all of these drugs, not the first day, but if the patient has still urine microalbumin that's present or GFR that's falling, to do that to benefit the kidneys. And of course, no NSAIDs, no COX-2s, no X-ray dye studies. But the key of what you're going to hear about is recognizing that the patient has kidney disease. Patients with chronic kidney disease don't even know they have it. Oftentimes, if the GFR has an asterisk next to it and it's low, the clinician doesn't even discuss it with the patient because the patient doesn't have edema, their blood pressure might be controlled. They're not discussing about their kidneys until the patient sees a nephrologist when they're stage 4 or stage 5, and then they know they have kidney disease. So we're very good about some of the other factors we do, where we use RAS blockers, getting A1C down, getting blood pressure down. We're reasonable at these, not 100%, but it's very important that you consider identifying the patient has chronic kidney disease, doing a urine microal, do a GFR, and inform the patient and give them the renally smart drugs to benefit the kidneys, in addition to getting their A1C down and lipids down and avoiding nephrotoxic agents. So the last thing we talked about is semaglutide and the FLOW trial. And semaglutide in chronic kidney disease is very important to not only to lower heart disease, but the FLOW trial established that semaglutide will lower the major kidney events on top of the RAS blocker, lower MI, stroke, death, and be very beneficial to patients. The pillars of therapy we outlined already with RAS, SGLT2, nonsteroidal, and semaglutide. But low chronic kidney disease awareness is a problem. And it's important for all of us, no matter what field we're in, to do a urine microalbumin. And if it's over 30, the patient has early kidney damage. And if the GFR is low, they have lack of kidney function. And that's the combination. That patient has kidney disease already, even if it's stage 1 with some proteinuria, or stage 2 with the lowest GFR and some proteinuria. You should use some of the strategies we've talked about to benefit the patient's kidneys. And this is a team approach. So it's not just when the patient sees the primary care doctor. Yes, for our primary care colleagues, please do the screening with GFR and a urine microalbumin and identify to the patient you may have some early kidney disease, just like if they have early retinopathy or early nephropathy or underlying heart disease. If they have a high cardiac calcium score, you're identifying it early and do something about it. You have pillars of therapy now to use. You could dilate the efferent arteriole with a RAS, constrict the afferent arteriole with an SGLT2, use an aldosterone blocker such as finerenone to lower inflammation and fibrosis. And GLP-1 in the FLOW trial showed many different benefits that the drug might have. It's not clear which of the benefits it has. So we have lots of ways to treat the patients. And we should all be comfortable using these meds. Not only primary care, but endocrinologists and cardiologists should be knowing how to use these drugs with the aid of clinical pharmacists helping us on the team. Nephrologists usually get involved at stage 4 and 5. They want us to head off the problem. Sometimes I say if we use all these pillars of therapy, our nephrologists might be unemployed because they're not going to go on to end-stage kidney disease. And certainly nutritionists and care coordinators are very important. By doing this, we can dramatically lower risk reduction of chronic kidney disease and kidney replacement with dialysis later on, reduce hospitalizations, improve quality of life, lower heart disease, getting to blood pressure, cholesterol, and A1C goal is imperative. So we have terrific medications to utilize nowadays. So I'll close with our favorite combination, GLP-1 and SGLT2, the dynamic duo, working in complementary ways to not only lower A1C, lower heart disease, lower heart failure, but to benefit the kidneys in a major way. Thank you very much.
Thank you so much for your attention. Before we move to take some questions, here is the QR code to claim your CME certificate for this session, which is completely free. If you look in the chat box, you will also find a link to this, and we will show it again at the end, if in case you miss it. Now we have some time for questions. Right, we will start with questions. So the first question here is, given the heat map risk stratification, if a patient has a normal EGFR but a persistently elevated UACR, i.e. if it is between 30 to 300 milligram per gram, how aggressively should we up-titrate therapy before referring to nephrology? Leigh, would you mind taking this?
I'd be happy to. Yeah, no, this is a really good question. And I think this is honestly exactly what we see in practice, because the UACR, it's a marker of kidney damage. And usually that damage precedes the decline in function. And so you will frequently see a normal EGFR and an increasing UACR before anything really happens. And I think that's exactly when you need to start becoming aggressive. So we need to start, doing those ABCs, the A1C, the blood pressure, the cholesterol, but specifically using medications like SGLT2 inhibitors and also GLP-1 receptor agonists in order to really, bring that A1C and blood pressure and kidney risk down altogether, kind of like what Bob was just saying, the so-called dynamic duo. I love that picture. It's perfect. It says it all, really. So I'd say that is exactly when people need to be, heads way, way, way up and start getting aggressive.
Excellent. Thank you. Next. The next question is, we often see temporary spikes in UACR due to exercise or minor illnesses. What is the recommended workflow to repeat and confirm a positive result before formally diagnosing CKD? First of all, I will take this. I think the most important thing is we recommend you doing an urine albumin to creatinine ratio. We advise that when do we measure it? We measure it in the first morning void, if possible. Midstream collection, unfortunately, these doesn't happen in real life. When patients go to the lab, they already have gone to the restroom. But the best case is we ask them to do it in the morning, preferably. What happened if they exercised in the morning, or if they were sick and ended up giving a urine sample? We definitely ask them to repeat it. We would like to see that it is a persistent albuminuria before we go ahead and formally diagnose them with CKD and start implementing therapy. How soon do we repeat that testing would depend on, definitely if it's a minor illness, we want them to get over with it. If it's exercise, you may just advise them to take off for a day or two and then ask them to repeat it. Certainly, we want to re-emphasize that most organizations, including ADA, KDIGO, are endorsing that we would like to do an UACR, not just the dipstick, to confirm or to even diagnose CKD. The next question, please. The FLOW trial utilized a weekly dose of 1 milligram semaglutide. In clinical practice, should we still aim for higher doses, i.e. 2 milligrams or so, for superior kidney protection, or is the 1 milligram dose sufficient for renal benefit? Robert, you addressed this in your talk.
So in the FLOW trial, they titrated maximally to 1 milligram. They didn't use 2 milligrams. And interestingly, in the SUSTAIN 6 cardiac trial, they gave 1 milligram. Now, that doesn't mean 2 milligram won't have the same benefit, but they didn't say 2 milligrams lowered proteinuria more or lowered heart disease more. 2 milligrams does lower weight a little bit more and also lowers A1C a little bit more. And that's when we up titrate for A1C. But even giving the lower doses of semaglutide, 0.5 and 1, would still have renal benefit and cardiac benefit. So whatever the maximum that they could be on that would be helpful would be good. But there's nothing saying 2 milligrams will work better than 1 for kidney or heart protection, but it will for A1C and weight.
Excellent. Thank you. That's quite helpful. Next question. For a patient already on maximally tolerated RAS blockade and an SGLT2 inhibitor, what clinical markers, besides failing to meet A1C goals, should trigger the immediate addition of a GLP-1 receptor agonist? Leigh, would you mind taking it?
Yeah, I'd be happy to. I think for kidney disease, I'd say probably persistent elevated UACR and or declining eGFR, although I would think about a selective MRA potentially in that case too. I mean, a few years ago, the American and European Diabetes Associations came together and then they declared weight management as a co-primary endpoint for diabetes with A1C. So that's the other situation in which I might say, even if the person's A1C looks great, but you're thinking like, okay, what else would a GLP-1 potentially do? It would lower weight. And there is some effect of body weight on, really accelerating decline in eGFR as well. So tackling that as kind of an additional pillar might be some other area where it would trigger me to think about adding a GLP-1.
Excellent. Thank you. Next question. How should we manage GLP-1 RA therapy in patients approaching stage 5 CKD or those starting dialysis, given the limited dedicated trial data for the population? I will take this, and I totally agree that there is no dedicated trial in dialysis population. So let me handle that first. We have observational evidence, as I mentioned during the talk. The key challenge for patients on dialysis to get listed for transplantation is a higher BMI. Where this drug come in handy is to definitely help with weight loss, to get them listed for kidney transplantation. The observational evidence show that there is a mortality benefit yet to be proven in trials. How about if there are patients on stage 4, advanced stage 4 CKD and reaching dialysis? And I think those patients can be continued on semaglutide or any other drugs that they are on at this point. They do offer beyond kidney benefits. As Dr. Busch mentioned, that there is benefits for cardiac and other aspects. So we do want to take care of majority of these patients, unfortunately, die of cardiovascular disease. So we are cognizant of that. So for both those populations, there are unique benefits, and I would suggest continuing those therapy. Next question, please. We have discussed the 4 pillars of therapy. In a primary care setting, is there a recommended sequence for introducing these agents? Or should we be aiming for a simultaneous quadruple therapy? Robert, you touched on during your talk. Could you please expand?
Yeah, so unlike in heart failure, where for patients in the hospital, they blast them with all the pillars of therapy pretty quickly. They call it goal-directed medical therapy. I think that's what cardiology call it when they give Entresto and spironolactone and SGLT2 and beta blocker. Here we do things that, we're not waiting years to do it. And as Leigh said before, if you have residual urine damage with proteinuria, you would add a second drug or a third drug or a fourth drug, and the drugs tend to complement with each other. But you might roll that out over a period of time, maybe over each visit that you see the patient, you're adding the other drug. And in terms of the order of the drugs, I mean, for example, the SGLT2s might offset some of the hyperkalemia of the RAS or of the finerenone. The GLP-1 would add additional weight benefit to some of the other drugs. So, I don't think there's a specific order. Usually people are starting the RAS just because they've done it that way for 20 years now. But whatever comes second or third or fourth, I don't think the order matters, as long as if there's residual proteinuria or worsening renal function, you could keep adding. You have other drugs to add. So we're very spoiled that we have lots of ways to help the kidneys now.
Absolutely. That's well put. Can you have the next question, please? With the addition of finerenone and RAS inhibitors, hyperkalemia is a major concern. Does concurrent use of an SGLT2 inhibitor significantly mitigate this risk? Leigh, please.
I'd say no, not really, no. I mean, I think, we don't really see much in the way of electrolyte changes with the use of SGLT2. So I would say no. I mean, if someone has real hyperkalemia, and again, Sankar, you could speak to this more eloquently than I can, because I don't personally prescribe a lot of potassium binders, but I don't know if you want to comment on that.
Certainly, yeah. So we do, I mean, the evidence there suggests that addition of SGLT2 inhibitors to finerenone lowers the risk of hyperkalemia. Potentially, there is some potassium wasting with SGLT2 inhibitors. It depends on where you are. I mean, certainly if you are in 5.5 and above, I doubt that it will have an effect as you noted. But if they are in the 4.8 or 5, then you don't anticipate that with the addition of SGLT2, it might benefit to lower that a little bit. Yeah. Can we go to the next question, please? Patients often experience a slight dip in eGFR when starting SGLT2 inhibitors. Should we anticipate a similar initial dip with GLP-1 RAs, or is their mechanism purely metabolic anti-inflammatory in the short term? Robert, do you want to tackle this?
So I think with the hemodynamic changes of SGLT2 and even with finerenone, you might see that dip. I'm not used to seeing the dip or a lot of information on the GLP-1 dip. I know Dr. Bakris used to always say, as long as the creatinine didn't bump 30%, don't worry, hold tight of what you're doing and don't worry about it. Because some people, they measure the creatinine early on, see it goes up a little bit and they stop the other therapy. So we should just be cautious not to do that kind of thing.
Excellent. Okay, now we have no more time for question and answers, but we just want to say thank you so much for joining us. Importantly, you will now see on your screen the QR code for today's session. You will need to scan this to claim your CME certificate, which is completely free. This will also be placed as a link in the chat box. I hope you found today's session helpful and interesting. It's been a real pleasure to host you all. If you have enjoyed this session, please be sure to check out other resources on medalleducation.com, where you can claim your CME credit for participating in all other free CME programs. Once again, thank you again for joining us this evening. Good evening.
As part of today's program, we want to pause and center the patient's voice. While we've been discussing guidelines, screening strategies, and treatment approaches, it's equally important to understand how these concepts are experienced by people living with diabetes every day. To help bring that perspective forward, we're joined by a patient advocate and representing Diabetes Sisters, a nonprofit organization dedicated to improving the health and quality of life of women living with diabetes. Thank you so much, Anne, for being with us today.
Oh, it's my pleasure. I'm always happy to share my experiences with others.
Great. So to start, could you briefly share your journey with type 2 diabetes and when kidney health first became part of the conversation?
Well, I've been dealing with this for over 25 years, and the diabetes came second as far as symptoms. I had a heart attack, oh my gosh, almost 25 years ago. And at that point, I didn't know I had type 2 diabetes. And I had no idea there was any connection. So one thing was affecting the other. And so I wasn't even told that there was a connection. So I just was dealing with my heart issues. And then when I learned I had 2 diabetes, I was treating that as a totally separate health issue. It wasn't until I don't know how many years later, quite a few years later, that the chronic kidney disease came into play. And that was, you know, through my having blood tests on a regular basis to see how everything in my system, you know, in my body was working. And I found out those things were not working.
Thank you for sharing that. And it really highlights how kidney health often becomes part of the diabetes journey over time, rather than from the very beginning. Your care team discussed kidney health with you. What did you understand about how diabetes can affect the kidneys?
I'm embarrassed to say I didn't know. And again, this was over 25 years ago. And I don't know if it was discussed with patients, saying that one thing could affect the other. I had no idea that by not managing my blood sugar levels, it caused inflammation in other parts of my body. So it affected my heart. And from what I also understand is that diabetes could be there for 10 years before you know you have it. And so in that case, it means that my heart was being affected and my kidneys were being affected. And it wasn't until the extreme occurred that my real education journey began.
That perspective is really helpful, and it underscores how much of this information isn't always clear to patients early on, which is, of course, very natural. Do you recall having tests like blood work for kidney function or urine tests as part of your diabetes care? And how were these explained to you at the time?
Well, the diabetes care started after the heart attack. And so that's when I started having blood tests and finding out different things that were going on. At that point, I had no kidney issues. So I also think that in my situation, the appearance of a kidney stone exacerbated things. And I wound up, and I don't know if this was about 10 years ago, that one of the kidney stones embedded itself in my kidney. You don't feel it if it's not moving, and it caused an infection. And when I had the infection, again, you don't feel it. So I didn't know that my kidneys were being affected. There was maybe a slight elevation of my creatinine level. I mean, very slight, not to the point where I had to worry about it. But once I had this infection and it was raging through my kidneys, it threw me into a much higher level of kidney disease. I mean, when I found I had it, I think I was already at stage 3, which is also not uncommon. I mean, since it's a silent disease, as is diabetes, unless you're on top of it and knowing what to look for, these things can progress.
Thank you for really describing that experience for us. And I guess it really shows how important clear explanations are when routine tests are ordered. Looking back, what helped or made it harder for you to understand the importance of kidney screening?
Well, that came along, as I said, after I had the infection. I was already part of a group called Diabetes Sisters, because I knew I had diabetes, and I was very lucky to meet somebody that was already part of the organization. And she invited me to join and check out a meeting. These were in person at that point. And my education really began then. It was just a giant plus that this came into my life. And I was meeting and talking with other women through Diabetes Sisters. So I was able to branch out my education and start learning more about what I needed to do to keep my blood sugars to manage them, because I can't control them, but I can manage them. And by managing my blood sugar levels, it keeps my kidney healthy. And because I didn't mention this and we didn't get to this part yet, but the chronic kidney disease advanced to the point where I did need a kidney transplant. So I have been through everything from heart attack to diabetes to then having to absolutely need a kidney transplant. I was very lucky in that my son was a perfect match. So I was able to have him be my donor. So again, that's when I also turned to the National Kidney Foundation. So working with Diabetes Sisters, and then becoming familiar through Diabetes Sisters with the National Kidney Foundation, it rounded out my education, and I realized I had a lot of work to do to try to keep myself healthy. And all the information was out there, but I never knew it before.
These are very important insights, and it really highlights how community, which you've mentioned, and communication and timing can make a real difference in patient understanding. When treatment options were discussed, how involved did you feel in decisions about your care?
Very. I had an amazing nephrologist. And as a matter of fact, I did a Zoom session with him for the National Kidney Foundation. They wanted to have a patient speaking to a nephrologist, and it just so happened my nephrologist was available. So he was able to ask me very guided and pointed questions so that anybody that was listening to this particular session would know what to do. And so that was an incredible help to me because I learned even more during that session. But peer group support, again, with Diabetes Sisters, is what led me on this journey and oh my gosh, it made such a difference. And I was able to speak with others that had already experienced some of the same things. And journeys may be different. We may get to certain places at a different pace or through, just different health issues. But if we're able to share our experience and learn something from someone else, it just makes a world of difference.
Thank you for sharing that. Your experience here really reinforces the role of shared decision-making in helping patients feel engaged in their care. If you could share one message with healthcare professionals caring for people with type 2 diabetes, what would you want them to understand from the patient's point of view?
Well, when it comes to understanding what we need to do, it would be great if the doctor approached it in such a way that it didn't scare off a patient. I know that may sound extreme, but if someone's not really familiar with diabetes, type 2 diabetes specifically, they hear that and they get scared. It's like, oh my gosh, what did I do? People blame themselves. And it's important for people to know it's not your fault. Things happen. We don't understand why exactly. Part of our education is to better understand what may have happened. And I want the doctors to, and actually not just doctors, but PAs and health educators to realize that you may be dealing with somebody that the second you say, you have type 2 diabetes, they stop listening because they get it can make you very scared. And people don't realize that we can manage how we deal with it. We can stabilize how we with our eating, with medication. And I want them to realize that we have to work together as partners, so that I've heard doctors, when I've gone to different groups, say that they give someone the diagnosis of type 2 diabetes and the patient doesn't necessarily come back right away because they're so upset. And so I think it's really important to give patients hope and say, you can be fine. You don't have to go through certain things if you're willing to work, let's say, to change your diet, to change your exercise routine. And if things do progress, we can work together so that you're not going through all these things that cause you so much anxiety.
That's a very powerful message, and one that's very relevant to everyone listening today. What do you think would most improve the patient experience when it comes to protecting kidney health and diabetes?
Well, to me, it starts with managing my blood sugars, because if I have out of control A1C, let's say my daily blood sugars are going up and down and up and down, and I haven't made any changes, this can exacerbate what's happening with my kidney, because the inflammation that's caused, and this is how I understand it, by out of control, unmanaged diabetes is going to cause the kidneys to not function the way they should. I never understood that how much our kidneys, can I say, are in charge of what happens. I never understood that it has a lot to do with blood pressure. It has to do with everything. And so it was important for me to learn the connection with managing my blood sugar levels to keep my chronic kidney disease at a particular level. And I wish I had learned that earlier in my diagnosis, because I didn't. A lot of this education came afterwards. Again, working with Diabetes Sisters, working with the National Kidney Foundation, and with other groups. And I had to not beat myself up saying, oh my gosh, what did I do? I couldn't, if I had that attitude, I don't know how I would have dealt with all of this.
Thank you for that perspective. And it really emphasizes how small changes can have a meaningful impact on the patient experience. What advice would you give to someone who's newly diagnosed with type 2 diabetes about being proactive with their kidney health?
Well, it's important to start your education quite often with someone who is a diabetes educator. Go to a registered dietitian if that's the direction you want to go, but make sure that they specialize and they really understand how diabetes works. My first dietitian, and this is quite a while ago, had me eating a large number of carbohydrates as part of my daily, make sure you have this many carbohydrates. They didn't mention protein really. You need to get this many servings. And my diabetes was getting worse. I was overdoing the refined carbohydrates, or the things that my body was happy to turn into sugar. And I went back, let's say 3 months later or 6 months later for another checkup, and my A1C had not improved, even though I thought I was doing everything that I should, because that's what I had been advised. Then when I went to somebody recommended their diabetes educator, who was a registered dietitian specializing in diabetes, that she explained so much to me, and that turned things around. And I was able to, at that point with medication, manage my blood sugar levels. I had no idea at the initial stages how much what I ate affected my levels.
And you mentioned community. Would you like to add anything else to that?
I really would. And I may have mentioned this already in passing, but community support, peer group support, like Diabetes Sisters offers, opens up a world to patients that they may not get necessarily anywhere else. Some people do go to hospitals for their education, but they don't have access to others who are dealing with what they're dealing with. And so Diabetes Sisters offers this to everybody, any place. We have a website that has so much information. There are webinars, there are live sessions, and these are available to us at all times, no matter where you are in the world. In my particular meeting that I attend monthly and co-lead, we have people from Canada, we've had people from Central America, we've had someone, I think, from Costa Rica, and they find us online. They search for keywords, diabetes, they search for women, health, and fortunately, Diabetes Sisters shows up. So we're available to women all over the world, and they're meetings all the time. So we're available. We're available to so many people, and it makes a huge difference to those that may be completely alone in their community.
That's a very thoughtful advice and a helpful note to end on. Thank you so much, Anne, for sharing your experience and for the work you do through Diabetes Sisters. Your perspective brings valuable context to everything we've discussed today. And thank you to our faculty and audience for joining us for this program. We hope today's discussion supports more patient-centered care for people living with type 2 diabetes.